wasting much
Yeah,
time, we would
thank
like
you.
to
Thank you,
hear you.
Madan. It's a pleasure to be here.
Welcome, sir.
Yeah, in this AMOGS webinar along with the Kerala Obs and Gynae Societies on psychosexual health. Hello.
Yes, sir.
Yeah. And it is a pleasure to be among friends, my dear friends like Dr. Ameya Purandare, Dr. Fesi Louis, Dr. Ashwath Kumar, Dr. Subhash Malia, and the young Turk, Dr. Rohan Palshetkar. I just heard Dr. Ameya wishing all the best to Dr. Madan Kamble and Dr. Prerna Keshan, but I don't think they need any more best wishes for the elections. They need best wishes for their term. But of course, all the best to Dr. Kunjamoidin. Today is a very important issue, and this is a cause that Madan Kamble and the Foxy, they have been championing. And this is on sexual dysfunction in different situations. And today we are talking about sexual dysfunction in infertility and sexuality in pregnancy and psychosexual issues in adolescence. Kerala is not only geographically beautiful and also has great friends, but Kerala also is unique in the sense that in terms of education and healthcare, the two key indicators, Kerala always leads this country from the front. And they brought down their maternal mortality ratio to international standards a long back. And this is a model which other states would like to follow. So I think we are doing better now all over India gradually, but I think Kerala, which has been the front runner in terms of health and education. So it's always a pleasure to interact with the doctors from Kerala. And I always say that in different parts of the country, when you go to give a lecture, you can, from looking at the behavior of the audience, you can make out where you are. And I think what is typical of Kerala is that if you go for a conference, from morning 8 o'clock till 6 p.m., the hall would be full. You never get such full halls anywhere else. But the moment it stops and there is a cultural program and dinner, within half an hour, 1 hour, people would have dinner and leave, and there will be nobody left in cultural programs, which is more or less the reverse in many other parts of the country. So anyway, I think it's great, and we are waiting to hear from Dr. Kunjamoidin and Dr. Saria Sridhar, and also the panel discussion moderated by Madan and Prerna, the two dynamic young to-be chairpersons of Foxy. Thank you very much for having me, and I wish you a great program today.
Thank you, sir. Thank you. Thank you for your blessings, sir. A string of stalwarts in this star-studded evening that we have, and none other than Dr. Bhaskar Pal, sir. We just heard the pathfinder for many of us in the fraternity, a clinician par excellence, and somebody who has led the organization from the forefront towards uplifting women's health in our country. So your exemplary leadership has brought the organization to its highest realm, and we are so very honored to have you amongst us. Thank you, sir, for all your blessings. We now move on to our guest of honors, Dr. Fezi Louis, the past VP Foxy. Can we have Sir's CV, please? Sir is the president of KFOG 2026 and the past vice president of Foxy. So we are so very honored to have you amongst us. The dais is all yours for your blessings, sir.
Respected chief guest, Foxy President Bhaskar Pal, and AMOGS President Ameya. And also we are bring greetings from all the societies of Kerala. We are grateful for this wonderful initiative by the Dr. Madan Kamble and Dr. Prerna. As Bhaskar told, the topic here is very important because usually compared to the other topic, which is least discussed, but it is very important topic, and we are happy for involving Kerala leaders, Kerala societies here. We are happy that Kerala's past Kerala Federation Presidents Dr. Ashwath, Dr. Kunjamoidin, and Prasanna Kumari Madam are here, along with almost all the societies has been represented here. And we are eagerly waiting to hear this, because this is a thing which is least discussed, but always all of us come to face this problem in our practice, and it is been there are a lot of things to be learned and discussed in this field. And we are also happy that AMOGS, I think Amia will be knowing that. As told, we are discussed with Subhash and Dr. Rohan, who is the secretary. We are planning in subsequent few more webinars in similar few topics between AMOGS and Kerala. I am not wasting time because all are eagerly waiting. Wishing all the best for the Foxy Committee Chairperson for Dr. Madan, Dr. Prerna, and our Kunju Moideen, who is also contesting for the Foxy Committee Chairperson. And we hope with all your support and all your academic excellence and your vibrancy, the coming years of Foxy will be coming to greater heights with the collaboration with all the people like Madan, Kunjumoidin, and Prerna. This shows an example of even though our country is having different states and represented by different people from different things, we can combine and do lot of things for the betterment of womanhood of India rather than confined to your own states. With this, thank you for inviting me. Wishing all the best for this webinar. Thank you.
Thank you so much, sir, for your blessings. We are so very honored to have you amongst us. We have AMOGS Secretary General, Honorable Secretary Dr. Rohan Palshetkar with us. Dr. Rohan Palshetkar is not only a friend, a leader, a guide, but the backbone and the conscience of the Young Talent Promotion Committee, of whom I'm going to take up in the month of January. So, Rohan, the guys is all yours for your pertinent blessings.
Thank you so much.
Rohan?
Firstly, I want to say is that it's fantastic that the two committees which have come unopposed are still conducting programs through and through, even though there are no elections over here. So I'm very happy that you all are both taking the mantle forward and showing the enthusiasm even before the term has started. And I think that gives kudos to both of you all to show your commitment towards academics. And the fantastic part is you've created a collaborative series where Maharashtra and Kerala are getting together and working on such important topics. See, we both have our practices which occur in two different states, but the experiences that we would face would be different in each of the states. So it's fantastic that we're going to get an input from both states and understand what we can take from each other's practices and apply to our day-to-day practice. So I think that's a fantastic job that you all have done. I can always see my mentors. What can I say about Amay sir? We've been installed as the youngest president of AMOGS and the youngest honorary secretary of AMOGS, and we have big shoes to fill in. But with Amay sir there at the mantle, it becomes so easy to conduct programs, and it's so simple because all I have to do is call him up and he's like, Rohan, if you're doing it, go ahead, let me know what happens with it. So I think that kind of freedom and the kind of trust that he puts in me as an honorary secretary really gives me an ability to carry out these programs through and through, and also in our chairpersons. Fessy Lewis, sir, what can I say? Sir has also been a mentor, not only in Foxy, but in ISAR as well. The best part is whenever you call him up, he picks up the phone and he's always available to you. That's the best part about him. Ashwath sir, he was the president in 2019 when I sort of began my Foxy journey as an very active member of Foxy. Amay sir was the joint secretary, Ashwath sir was the vice president, and I always joke that I was the joint secretary to the joint secretary and the vice presidents, where I actually got to learn a lot from them, and their mentorship really meant a lot. Just moving on, I wish Kunju Mohiddin sir all the best for his election. Subhash is a dear friend, and Subhash has always been someone who's been supportive. And I love the topic that you have taken because they are topics which are not covered on a day-to-day basis. And I'm glad that these topics are being chosen, spoken by the right people so that we can have the right messages go across. So thank you very much.
Thank you, Rohan. Your prudent leadership and your unwavering support and dynamic tenure is always a motivation for the youth of the country. Thank you so much for being here with us.
Thank you.
I'm going to hand it over to Madan to kindly proceed for the next guest of honor.
Yes, thank you, Rohan. We welcome the next guest of honor, Dr. Ashwath sir.
So, good evening, everybody.
And
Oh, no problem.
yeah, welcome, sir. Yeah,
Thank you,
nice
thank you, thank you. Good evening, everybody. First of all, I thank AMOX and especially Madan and Prerna for inviting me for this webinar. Along with, I'm so happy that I got an opportunity to be in a webinar where Amaya is the president and Rohan is the secretary. Both of my very close friends, in not only in AMOX and Foxy, we have been friends before that also for a long time. Amaya, with friends with Amaya, I think 25 years before. So before that, we were just workers in baseline workers in Foxy, which we did not have any post, but then also we enjoyed our friendship. And Rohan, one of my favorite madams, Nandita madam's son. That was what initially I came to know about Rohan. Later, he has all the skills and vision of madam itself. So I know that AMOX is traveling into great heights. So thank you so much. And as Rohan told exactly the same, I wanted to tell that Madan and Prerna, after winning the election, also they are conducting this. I thought 2 days before, I thought they will not be conducting it because they're already elected as. So it is not like that. This is what had to be shown to all the people who are contesting, as well as it's a motivation for them because they started working from day one onwards. So hats off to them. And I'm very happy that our close friend and my close friend Kunju Moideen is standing for election this time. And I hope that he will win the election and be with you in your team. So all the best for Kunju Moideen for contesting this election. So coming to all the people and all the senior members of my Pesi is there. My close friend Pesi is there. He is the now the present president of KFOG, and under KFOG he has developed so much collaboration with so many societies actually. So many state chapters, and one thing which he has done is with a state chapter with AMOX, which is a very good state chapter which we can collaborate, and they are brilliant people like Amaya and Rohan is there. This collaboration will give knowledge and will help both the teams to develop their knowledge, and through webinars, which is very handy. You can sit at home and listen to all the topics. So learned speakers from both the interact with each other. As Rohan was correctly telling, we can get knowledge from both ends, how management different in different parts of the country. So I'm so happy to see all of them, all the seniors here and all the chairpersons, all the speakers, everybody is here. And thanks to, I did not see, and one more person, Subhash, my friend, always there to help. He is a secretary like Rohan. He is a secretary in Kerala, who is the right hand of Fesi. And with Subhash and Fesi, Amaya and Rohan, we can do wonders in the profession. So thank you so much, and all the best to all the speakers and the chairpersons of today's program. Hope that this more frequent programs will be there in the future also, and the collaboration will be keeping up the collaboration for years with AMOX and KFOG. So thank you so much for inviting me to this program, and proud to be a part of any AMOX program. Thank you.
Thank you, sir, for your kind presence and kind words and blessings. And thank you for having you with us today. Once again, I think Dr. Subhash has not joined. He's busy, I think. We will welcome him whenever he joins. Once again, I thank all the chief guests and guest of honors for having us here and for blessing for this particular program. I welcome all the office bearers and delegates and everyone here. So we will move on to scientific sessions. Mayur? Yes. Yes, session 1. Can I have the slides? Yeah, our first session is on sexual dysfunction in infertility, and we are so lucky to have eminent speaker, Dr. Kunju Moideen. who is the president of Peripheral Society and past president of KFOG. We have got the chairpersons for this session, Dr. Cynthia, who is the senior consultant at Rajagiri Hospital and currently secretary of Angamali OBGY Society. Yeah. Next, Dr. Neeta George, who is the president of Thrissur Society. I welcome ma'am. Dr. Ajita ma'am, who is the president of Calicut Society, and Dr. Hema ma'am, president of Palakkad Society. Hema ma'am has not joined, but we welcome all the three chairpersons, and I request the chairpersons to introduce Dr. Kunju Moidin sir. Yeah, thank you so much. Yeah, anyone can introduce. Yeah. Dr. Cynthia also, please introduce sir.
Respected students and dear friends, it is my privilege to introduce Dr. Kunju Moidin, who is past president of the Kerala Federation of Obstetrics and Gynecology. And presently he has a case, he's the medical director of ARMC hospitals in Kerala, and a great entrepreneur also. He has 28 years of experience in the field of reproductive medicine and gynecologic surgery. And he's a academic director of Birla Institute of Fertility Sciences also. He's a senior consultant at Birla Fertility ARMC, Calicut and Peripheral Kerala. He was a former chairperson of ISR Kerala Chapter 2022-24 and the founder president of Peripheral Society in the year 2023. He was champion of ISR Awards, the Baghdad Award in 2020, and also the ISR Dronachari Award 2024. He's a great teacher and a great academician, and he's also the organizing chairperson of Yuva ISR Hyderabad 2016 and 2023, Fertilization 2018, Testicon 2024 and 2025. And he's also presently, we are very hopeful that he is the candidate for the FOCI Infertility Committee Chairperson 2023. And hopefully we'll see you there. And I'd like to welcome Kunju Moidin sir for this topic which we are all very eager to hear because it is rarely discussed, and that is sexual dysfunction in infertility. Over to you, sir. Kunju Moidin.
Yeah, thank you, Dr. Cynthia. Can I share the screen? Hope you can see the screen, right?
Yes, sir.
Yeah. Good evening, all. Respected President Foxy, Dr. Bhaskar Pal, the President AMGOS, Dr. Ameya, President KFOG, Dr. Fesi, Secretary AMGOS, Dr. Rohan, Secretary KFOG, Dr. Subhash, the coordinators of today's program, and the chairpersons elect, Dr. Madan and Dr. Prerna. Thank you for having this opportunity given to me. And today the topic is, as everyone rightly pointed out, it is something which is rarely being discussed in the infertility programs or webinars, the sexual dysfunction in infertility. As we all know, that is an integral part of, to have a conception properly happen, a proper sexual intercourse is vital part of it. And the ability to have sex from the male or female, that makes the equation very complementary. So the objectives of today's discussion, understand the bidirectional relationship between infertility and sexual dysfunction, because sexual dysfunction can result in infertility. Infertility can end up in sexual dysfunction as well. And recognize the common male and female sexual dysfunctions, the basic things what an infertility people need to know, what a gynecologist need to know. Identify sexual dysfunction in infertility clinics, what are the red flags when you should refer, and understand evaluation and management strategies in this occasion. So why talk about sexual dysfunction? Is it so important? If you are sitting in an infertility clinic, is it so important? Should we just treat the infertility, give them medicines and take them for ART? No. Sexual dysfunction is one of the most neglected causes of infertility. Very often we forget to take the history properly. Many couples undergo extensive investigations while the real problems remain unrecognized. Sexual dysfunction may cause infertility, or it can result from infertility as well. It can worsen the treatment outcomes. And most importantly, that proper sexual intercourse and lesser gap between abstinence is very important to have a proper healthy sperm without DNA fragmentation. That is just an example. And it affects the marital satisfaction and the quality of life ultimately. What is sexual dysfunction? Persistent disturbance in number one, sexual desire or sexual arousal, or desire to have sex, or whether that woman or man is not having any arousal to do the sex physically, but they may get arousal virtually by looking at the videos and so on. And erection, at the proper erection at the proper time, that is, and proper duration, that is very much important. And lubrication for a proper atraumatic sexual intercourse from the woman's side, and proper orgasm, whether they are reaching the proper orgasm or just before reaching that orgasm they're having ejaculation, and a proper ejaculation after an appropriate period of time, not a premature one, an appropriate period of time to deposit the healthy sperm in the vagina, and there is sexual pain, resulting in distress or impaired relationship function. So these are the 6 important points when we are discussing about the sexual dysfunction, whether it is in the woman or in the man. So what is the magnitude of the problem? So in the general population, of course, it is almost equal, like in the infertility, female 25 to 63% as per the many studies, and the male around 10 to 52%. Infertile population, see, this is the biggest point which you all have to notice. In an infertile population, approximately 50 to 70% of women have sexual dysfunction. It's a bigger eye-opener for all the specialists and the gynecologists. And the male, again, it contributes to equal 50 to 60%. So this is the actual dangerous volcano that we are not addressing. And you have to properly address this point. And you can avoid a lot of unnecessary treatment, which can be avoided. And that is creating a lot of financial burden to the patient. And sexual dysfunction is significantly more common among infertile couples than those who are having the children. So the vicious cycle, so it starts from infertility, then that creates stress, anxiety and depression, sexual dysfunction, reduced sexual satisfaction, relationship strain, that again relates into the increases the chance of further infertility as well. So the vicious cycle continues. It is very difficult to break. Today I had consulted, I had a patient, the wife is a gynecologist working in US, and the husband is an IT engineer. So both of them have been married for 7 years. The woman is 34 years and the husband is 35 years. See, they didn't have even one sex between them. I don't know whether they had sex with others, but between them as a husband and wife, they didn't have a sex, and the marriage is non-consummated. So when we are taking the history, they escaped to the US just because of the family surroundings and the pressure from the family. So what happens immediately on the next day of marriage? The mother-in-law, father-in-law will come and ask the boy or the girl, "Is everything all right? Could you have proper intercourse?" Unfortunately, they are just getting ready only, might be. Exactly after the next menstrual cycle, the mother-in-law or the mother or some relatives will ask, "Did you miss the period? Have you become pregnant?" So this actually haunt them very differently, and that will give a lot of stress to them. So very often the young couple, as such, nowadays the girl and boy, they don't want to get married. Even if they get married, they don't want to have children. So in these surroundings, in these pressurized situations, they just escape from that surroundings and they go abroad and work. And from there, they'll just get involved in the work alone. And why does infertility affect sexuality, scheduled intercourse? I think that is the biggest trauma to the infertile couple. You look at you give from the day to some ovulogens on the day 9, 10, 11, you see the follicle. and you show the piston to the husband and wife, tomorrow onwards, 10 days, you are supposed to have sexual intercourse. Gone. That 10 days, they are not able to have sexual intercourse at all. See, rather, you can tell on all the appropriate possible days in the cycle, you have the sexual intercourse, not to have not to advise them this date, 10th of this month to 20th of this month, you should have intercourse. The wife will be waiting to have the intercourse. The husband, nothing will be working, and wife will be just showing the piston to him again, and that will end up in a calamity. And second thing, fear of failure. So the fear of failure, it is something that gives the performance pressure. So the performance pressure is by the clinician as well as by the horrible, I don't see horrible wife or the demanding wife. Rather, because it is her need to become pregnant, for that husband is having the active role. So the husband, poor husband, very often fails because of the fear of failure and repeated negative pregnancy tests. They try this month, next to next month, 2 days, the periods get postponed, all the pregnancy tests become negative. This is a big pressure for them. And the financial burden after each and every cycle, they are paying the consultation fee, they're paying the scan fee, they're paying the drugs, they're taking injections, nothing happens. And the family pressure, as I already mentioned, both the sides, they will just excuse this couple, and the relationship conflict starts. Then a lot of things will happen. The wife may want to have child, the husband wants to have the house built up, then the career settled, then only to have child. Then ART related stress. Finally, all the stress will be mounted at the time when the couple is being advised the IVF. So sexual dysfunction in infertility clinic, what every infertility specialist should ask. So these are the few questions. Is penetration possible? So even you can have that visual aid something and ask them, is penetration possible? Is erection adequate? These are the most two important first questions. Is ejaculation happening or normal, or is intercourse frequency adequate? Very often we take the history of menstrual cycles, check the previous reports, we forget to ask anything about the sexual history. We just may ask, do you have proper intercourse? The husband and wife they will be very hesitant to tell no, so they say yes. But if you are properly interrogating them, then only these things will come out after asking some leading questions. Is intercourse painful? Another scenario. Or is desire reduced? So these are the few 6-7 questions. And every infertility specialist, or even a common, the general gynecologist, when the infertile couple, I'm not telling the infertility specialist, whenever an infertile couple come to a specialist, we should ask all these questions. So male sexual dysfunction disorders, common disorders, erectile dysfunction, delayed ejaculation, low libido, premature ejaculation, retrograde ejaculation, and orgasmic dysfunction. So right from the erectile dysfunction, premature ejaculation, delayed ejaculation, retrograde ejaculation. So ejaculation itself can be premature, retrograde, or delayed, low libido, or orgasmic dysfunction. So sexual dysfunction in infertile men, most common problems. So what I mentioned earlier is something that is in the general male, but when we are coming to the infertile men, reduced sexual desire. Ultimately, this has become mechanical. All our advices of timed intercourse gone. It is mechanical. Reduced satisfaction because they are doing mechanically. Erectile dysfunction, which is very common during that 10 days, and premature ejaculation, which is very disturbing, and an orgasmic dysfunction. Reported prevalence, erectile dysfunction and premature ejaculation affect nearly 1 in 6 infertile couple. So it is not very uncommon. It is a very big reason for the relative infertility. So erectile dysfunction is something persistent inability to attain and or maintain an erection sufficient for satisfactory sexual performance. So all the words are very important. Inability to attain or maintain an erection sufficient for satisfactory sexual performance. It can be psychogenic, the major chunk, organic, or mixed in some population. So what are the consequences? Reduced intercourse frequency. Intercourse frequency, when it is reduced, the cycle frequency, the chance of pregnancy, that comes drastically. and failure of semen deposition unless to have a sexual intercourse. There are even the educated men who do not know whether the penis has to go inside the vagina. That will happen between intercourse will happen, and they don't know it is happening at all. So the failure of semen deposition, increased timed intercourse anxiety. So that is a performance anxiety which happens only during that 10 days. As soon as the clinician tells you should have intercourse this time, reduced relationship satisfaction, that is that vibe will not be matching between the husband and wife. So that should be properly aligned. So that needs proper time build-up and delayed conception. So very often they want to delay the conception till they reach at a stage where they lose all the desire. So what are the causes? It can be organic due to diabetes, hypertension, cardiovascular disease, obesity, smoking, hypogonadism. Of this, the most important menace is the obesity that will reduce the testosterone concentration, increases estradiol, and all this will interplay in causing the dysfunctions, erectile dysfunction. Psychologically, of course, the performance anxiety, depression, mainly resulting in because of the failure to have the proper intercourse. And these are the most important points in the psychological part. So this is an important clinical pearl. Erectile dysfunction may be the earliest manifestation of a cardiovascular disease. Not only this is for your patients, all the audience, you also take care that just mind erectile dysfunction is there. You have to correct it or evaluate for an impending cardiovascular disease. Within 3-4 years, these people are more prone to develop the cardiovascular issues. Men with erectile dysfunction has significantly increased future cardiovascular risk within 3 to 4 years, almost 25 to 30% increased risk. So always think beyond fertility. So premature ejaculation, yes, it is something very critical issue. Ejaculation occurring before or within about 1 minute of penetration or before starting the penetration associated with inability to delay the ejaculation and personal distress will cause. And see, that particular person will not be able to deposit the sperm inside the vagina. So that's why here the woman telling that haul faster than a speeding bullet, things suddenly makes sense. And ejaculatory dysfunctions, it can be difficult, different types of ejaculatory dysfunctions, starting from premature ejaculation, delayed ejaculation may not be happening, and ejaculation, retrograde ejaculation, due to various issues, the ejaculated semen will be going back to the urinary bladder. And causes can be diabetes, neurological disorders, spinal cord injury, pelvic surgery, and few other medications. So the testosterone and fertility, exogenous testosterone is contraceptive. So never ever prescribe testosterone without properly checking the patient for the signs or the laboratory evaluations of testosterone deficiency. We should not prescribe testosterone that will result in severe oligospermia or even azoospermia. That's what happened when the anabolic steroids are being taken in the gymnasiums, the fitness centers. So exogenous testosterone, that is very contraceptive, that suppresses the LH and FSH, resulting in severe semen abnormalities. And fertility preserving alternatives for symptomatic hypogonadism. If the hypogonadism is symptomatic or clinically proven, the things like the clomiphene citrate, HCG, aromatase inhibitors, see, the letrozole is also found to be effective. And avoid testosterone therapy in women trying to conceive. Testosterone should not be given for erectile dysfunction unless otherwise proved, or it should not be given for patients with oligospermia or azoospermia. It should not be prescribed. It will spoil everything. I think that was the most important message I want to give in this particular talk. And female sexual dysfunction and DSM classification, female sexual interest or arousal disorder. So it can be sexual interest or arousal disorder. And female orgasmic disorder. So on one side, it is the sexual arousal disorder, or it can be an interest, lack of interest. Other side, it is orgasmic disorder. And the other one is sexual pain disorder, that is genitopelvic pain or penetration disorder or penetration anxiety, maybe due to some bad experience previously. So there is something like gold standard assessment tool for female sexual dysfunction, that is Female Sexual Function Index, FSFI. It assesses what are the things FSFI assess. One is desire. It is an interrogative scoring, and arousal, lubrication, orgasm, satisfaction, and pain. Again, desire, arousal, lubrication, orgasm, satisfaction, and pain. These are the 6 components of this scoring, and scoring range is 0 to 36, and to interpret less than 26.5, there is sexual dysfunction. Lower the score, greater the dysfunction. So actually, this is something which you don't need any equipment. You need only a chart of scoring sheet where you can take the history and do this scoring. So in infertile women, most affected domains, as discussed earlier, regarding the reasons: desire, arousal, lubrication, and satisfaction. Because it is a passive sexual partner, woman is a passive sexual partner, the lubrication can result from only a proper desire and a proper arousal, then only proper lubrication happens. Then only the proper satisfaction also happens with the sex. So when these things are absent, we very often advise them to use the artificial lubricants. Common associations with secondary infertility might be due to aging, or one partner do not want a second child, increasing age, and repeated treatment failure. That is a big stress for this couple. So what are the management algorithm for female sexual dysfunction associated with during the fertility treatment? Natural conception attempts, ovulation induction, IUI, IVF, repeated failure, all this result in declining satisfaction. This is a cascade that will escalate right from the initial advice of the natural conception. Another important challenge is the unconsummated marriage. That is again becoming increasingly more prevalent, mainly due to they don't have a time, they don't have a desire, they don't have any interest, they have a different sexual orientation, they may be a gay or lesbian. So because of the family pressure, they are getting married, and these all result in unconsummated marriage, failure to achieve successful penetrative intercourse after the marriage. An important but often overlooked cause of infertility can remain undiagnosed for many years. So what are the causes of unconsummated marriage? Male factors, it can be erectile dysfunction, initially premature ejaculation, then not happening, low desire or no desire. And female factors, vaginismus, again that pain of female sexual dysfunction, genitopelvic pain, and the fear of penetration. Performance anxiety is on one side, and the fear of penetration is on the opposite side. And couple factors, anxiety, lack of sexual knowledge, as I mentioned initially, and cultural myths. And consequences of unconsummated marriage: infertility, relationship conflict, depression, low self-esteem. So that is one of the most important things. These people will be felt looking very depressed. They won't look at your eyes. So if you take proper history, this all will come out. And marital breakdown, ultimately the divorce will happen, because that is a very valid reason for the divorce. And management, comprehensive assessment of both the partners, sexual counseling, sex therapy, comprehensive behavioral therapy, couple counseling, medical treatment, and ART if required. Because pregnancy has to happen in this couple, as otherwise, as I said, this cascade will get activated. It will the vicious cycle will not be broken. So if a pregnancy happens, their attention will change, the relatives' attention will change. At any cost, we have to offer them the most possible treatment for fertility, because then only their sexual dysfunction matter also will be addressed. So what are the red flags suggesting sexual dysfunction? Very important to know: male partner, erectile difficulties, inability to maintain erection, premature ejaculation, delayed ejaculation, avoidance of intercourse, excessive performance anxiety. So that is a summary of the things which I already told. And female partner, painful intercourse, fear of penetration, vaginal tightening, reduced desire, and lubrication, avoidance of intimacy. So, but this intimacy part, these couples, no, very often I have seen these couples will act very intimate. So if some couple is acting too intimate, you have to question them properly, because they will be trying to hide something. Either one of the partners, the difficulties, or the husband, if he has some difficulty, he mostly will find fault with the wife very often for even the silly things. So all these things you can notice in your OPD. Couple intercourse only during fertile window. So what is it? They are just got married to produce children, isn't it so? They think like that. Significant relationship stress, marriage not consummated, infertility more than 2 years despite normal investigation. It's a red flag. You have to take a proper history again and again before going for further treatment. So these are the common myths and misconceptions in Indian couples or Indian population. Male myths: masturbation causes infertility. Rather, I do advise these people, this one, the unmarried. See, it is a trend for a fertility checkup before marriage. So that time, they might have attended some religious functions. They might have advised masturbation is not supposed to do as per the religion. So I just advise them, see, this masturbation is quite required. They will have nocturnal emission. They might have come for that. So the treatment for nocturnal, the reason for nocturnal emission is that they are not doing any masturbation at proper intervals. So it causes the nocturnal emission. Masturbation reduces sperm count permanently, and they are going to be infertile. This is very big myth they are having. Night emissions causes weakness. Penis size determines fertility. My God, that is another challenge. You have to counsel them properly. The size doesn't matter. Age doesn't matter. So it's only numbers. So you have to properly tell them these are the things which do not have any scientific basis. Sexual intercourse should occur daily for conception. That is also another myth. So the wife will be scolding the husband for that matter. And female myths: intercourse during menstruation permanently affects fertility. The poor couple. Infertility is usually a woman's problem. That is a social myth. Pregnancy should occur within 1 to 2 months after marriage. That is actually the myth by the in-laws. And IVF guarantees pregnancy. Always you should tell that you are not putting the baby inside. When should an infertility specialist refer to a sexologist? You should take the service of a sexologist at appropriate interval. Immediate referral: unconsummated marriage, severe erectile dysfunction, vaginismus, persistent dyspareunia, ejaculatory disorders. Referral after initial counseling: persistent low desire, relationship conflicts. You can counsel sexual aversion, anxiety-related dysfunction, and some psychological trauma in the early adolescence or childhood. So before concluding, these are the take-home messages. Sexual dysfunction and infertility have a bi-directional relationship. Both are contributing each other. Sexual dysfunction is common but underdiagnosed. Always assess sexual dysfunction during infertility workup. Timed intercourse can become a source of stress. So be kind, at least be kind to the couple while advising this. Couple-centered management is always essential. It is the couple who has to have the children, not the husband or wife alone. Successful fertility care must address the proper sexual health. So thank you for the patient hearing. Before concluding, I request all the president secretaries have been assembled from AMGOS and KFOG to vote for me for the post of Infertility Committee Chairperson. Thank you for the patient.
Thank you, Kunju sir, for that extremely elaborate and extensively informative and enlightening talk. I hand it over to the chairpersons for their closing remarks.
Dr. Kunjamaydin, that was a very interesting talk, a very important topic that is very seldom discussed. And before going to that, I would like to thank Dr. Ameya and Dr. Bhaskar Pal for the lovely words about Kerala and its people, and about the Kerala health model of which we all Keralites are proud of. Thank you very much, and great to be the part of this webinar, this AMOG webinar. That a very, very interesting topic, Dr. Kunjamaydin. That is something which we all know, but we rarely discuss in detail with the couple when we are treating a case of infertility. Just one question can I ask you? in a patient, in a couple that is who has come for first time for treatment of infertility or putting on ovulation induction drugs, how will you advise them the sexual intercourse so that they are not stressed?
Yeah. So generally, this is you take your pistol and ask them you should have intercourse from 11th of this June to 21st of June. The next day onwards, very often they will have sexual dysfunction. That's what, and immediately after that 20th day, their sexual dysfunction will be corrected or self-corrected. So we should not advise them that the appropriate days. Let them have intercourse during any day of the cycle, alternate days, not to have every day. So that you give a casual statement, not to look at the husband very seriously, immediately the anxiety part will start. I think Dr. Madan will have something to add.
Yes, you are very right, sir. Actually, we should not
Alternate
advise
days.
Fixed days.
Just
Again,
alternate days is fine.
yeah, again the cycle of performance anxiety will start. They can enjoy their sexual life with their ease and convenience, but just we can highlight them. These are 4 to 5 days. These are the very fruitful. They should have contact, but otherwise they can enjoy with their ease.
And actually, wife has to be counseled properly. Otherwise, wife will really threaten this husband to have intercourse. She will be ready with everything. She will just threaten you. What I used to tell, even the rape woman gets pregnant, so you don't worry. Even if casually you have sexual intercourse, that will take care of.
You're right. This is the fact. Yeah. It was a wonderful presentation, sir. Congratulations. And thank you so much.
Very wonderful in-depth presentation.
Yeah.
Actually, I want to thank Dr. Madan. He has given a lot of inputs because I'm presenting this topic for the first time. He has given a lot of presentations, articles, and to make this presentation. Thank you, Dr. Madan, for this.
Yeah, but
All
your
the best
content
to
was
you,
very
sir,
nice.
for your
Yes.
electoral candidature.
Yes.
Yeah,
Best
all the
wishes. Yes. Best wishes
to
from
all
my
of you who
AMGOS.
are contesting.
Yeah. Best wishes from my AMGOS, sir. Okay. Thank you, Ajita ma'am.
Thank you.
Yes,
Thank you, Madam.
Prerna. Yes.
Okay. Thank you, chairpersons and speaker for the first session. It was extremely enlightening and elaborate session we had with a very insightful topic and very pertinent inputs. We now move on to our second session, that is sexuality in pregnancy, an equally important and prudent session. To chair this session, I request Dr. Anita K.M. Madam, President Kottayam Society, Dr. Lalita Khatambika Madam, President Alapuja Society, Dr. Prasanna Kumari B., President Adur Society, and Dr. Beena K., President Kannanur Society, to kindly introduce our speaker, Dr. Sapna Sridhar from Thrissur. If any of our chairpersons have logged in, kindly introduce our speaker. Do we have Dr. Anita, Dr. Lalitambika, Madam?
Yes, I'm
Yes,
Dr.
madam.
Anita from Kottayam.
Yes, madam. Yes, madam.
Dr.
Madam,
Sapna
kindly
Sri-
introduce Dr. Sapna.
Okay. Dr. Sapna Sridhar, whom I knew, is a consultant obstetrician at Mother Hospital Thrissur, where I worked some 25 years back. She is a state coordinator, Foxy Sexual Health Committee, executive committee member, Family Welfare Committee, Foxy, and she is a joint secretary, TOX, that is Thrissur Obstetrics and Gynecological Society. Her areas of interest are high-risk obstetrics, minimally invasive surgery, sexual health, cosmetic gynecology. And today's topic is as the previous like the previous one, it's a minimally discussed topic. Rarely only we discuss such topic, and we are all eagerly waiting to hear Dr. Sapna what she has to say about it. Welcoming Sapna to the dais.
Thank you, Anita Madam, for that introduction. And first of all, let me thank Madan Sir and Dr. Prerna for this invitation. And yeah, thank you, President and Secretary AMGOS and KFOG President and Secretary KFOG and the coordinators and also the chairpersons. Shall I share the screen?
Yes, madam.
Okay. Actually, there's heavy rain here, so in between, this one is getting cut. The internet connection, it's not very stable.
Ma'am, you can share as of now. If there is any glitch, we can also share your PPT with the tech people.
Okay.
ചന്ദ്ര റാണി ഭർത്താവ് തീരെ സുഖമില്ലാണ്ട് കിടക്കുക. ഇന്നലെ രാവിലെ പൊലച്ചിട്ട് ഞാൻ പോയില്ലേ.
Is my screen visible? Is the PowerPoint visible?
Not yet, madam.
I think not, ma'am.
Now?
Not yet, madam. Mayur. Mayur,
Yes, ma'am.
you can take madam's ID and share the PPT from your end, please.
Madam, I have to share the PPT to me first, then I can share.
Yes, give
Madam,
your ID
you can
to
share on
madam.
the WhatsApp group. I'll download it and I'll share it.
Okay. I'll share it in the WhatsApp group then.
Yeah. We'll wait till then, madam. Not an issue. If other chairpersons are logged in, we can have inputs from other chairpersons by the time this technical glitch is solved out.
Yeah, I've shared it in the group.
Fine. Mayur, take care,
Let me
please.
check. Let me check.
We have heavy rains very often now.
I'm sharing the screen, ma'am. Just confirm that whether it is right or wrong.
Okay.
Is it right, ma'am?
It's not yet. Yeah, correct.
So just tell me the next button, so I will change the slide, ma'am.
Okay. Can you put it in the slideshow? Oh yeah, thank you. Okay, so the first slide, yeah. So good evening, everyone. So we know this pregnancy is one of the most profound transformations in a woman's life. So we all know much attention will be given to the fetal growth, the nutrition of the mother, the some other medical disorders, all these things. But sexuality in pregnancy remains always a silent topic. So because it's very often surrounded by anxiety, myth, and unwanted or unanswered questions. So what we need to understand as clinicians is that sexuality is not merely about a sexual intercourse, but it also includes intimacy, the emotional connection, self-esteem, relationships, etc. So today we'll bring some of the often neglected conversations into the open. So that is what we intend. So this is just a question, before I start the topic. Sex during pregnancy is best avoided in all except primea gravida, placenta previa, history of preterm labor, and all of the above. So if you can type the answers in the chat box, we can review it at the end. Next slide, please. Yeah, so in 2000, the WHO defined sexuality as a fundamental dimension of human being. So it involves not just the sexual intercourse, but it involves pleasure, the relationships, intimacy, gender identity. So all these things are involved. It's not just about the sexual intercourse. So that is where we often mistake. Next slide. So we already know that there are three principal stages of sexual response cycle, that is the desire, arousal, and orgasm. So each stage has got its own physiological changes, and very often females are affected by various disorders in any of these stages. So apart from this age, there are other factors like age, relationship with the partner. Pregnancy is one of them. Then psychiatric or medical disorders, some other medications. So all these can affect any of the phases in this cycle. Next slide, please. Yeah. So pregnancy should not be viewed just as a a pause in the couple sexual relationship. Rather, it should be regarded as one step ahead in the ongoing development of this relationship. So during pregnancy, couples often they'll be facing different types of challenges like physical changes, like there'll be altered body image, then there will be difference in the desire and concerns about the baby's growth, and also the regarding the partner as well. The partner dynamics will also be changing. So all these can create some kind of anxiety, fear, and emotional distance. So if not properly discussed, then probably this can result in multiple problems. But at the same time, so that is what at each of these stages there can be a misunderstanding. So this has to be discussed openly. But at the same time, pregnancy can also be a period of tremendous uh, emotional growth. That is, there will be more intimacy. So deeper communication, greater intimacy, and understanding, mutual understanding. All these can also be there. So it's a paradox. On the other side, there's a misunderstanding, but on the other hand, there can be increased sexual growth as well. Next slide. So this is where we need to act. That is, a physician's guidance can be of great help, particularly in the previously infertile couple. As Kunyumaidin sir was talking about, that is about the frequency of sexual intercourse and infertile, when to act, when not to do. So all these things we need to guide them. So the interest in sexual activity can go in different directions. It can decline or it can increase, or there might be no change in this uh, this interest. So it can differ from person to person. Next slide. So there is no clear cut like consensus, which is normal, which is abnormal. So each woman is unique, each pregnancy is unique. So as I said earlier, some women may experience heightened sexual appetite, while others might be turned off because of their body's weight gain, distorted body image, fatigue, etc. And some others will not experience any change in their libido as compared to before the pregnancy. So it can go in different directions. Next slide. So now, what are the factors that are inhibiting, or what prevents from or the deterrence to sexual activity in pregnancy? It's basically three P's. That is the physical changes, physiological changes, and psychological changes. So when we come to next slide, please. When we come to physical changes, it will be in according to the trimester wise, it differs. Next slide, please. Also, it depends on various other factors like the age, the cultural. Sometimes it might be a taboo, or there might be some inhibition. Then physical changes, increased tummy. Uh, so all these can then discomfort, fear of fetal damage, partner sexual function. So all these can affect the sexual behavior of the woman. Next slide. So these are the various physical challenges. So we can, in the first trimester, we have like there is an increased nausea, vomiting, urinary frequency, urgency, back pain, then gastric reflex, then fetal movements. Of course, in the later trimesters, breast changes, genital changes, vaginal secretion. So all these are going to affect. Next slide, please. So early pregnancy is very often imagined as a very joyful time, and the couple they feel as a close unit. But while this is true emotionally, this is one of the most challenging phase as well in the relationship, because very often it will be affected by the hormonal changes, exhaustion, nausea, then breast sensitivity, etc. So all these can affect the women's physical as well as emotional well-being. And also, partner might also feel confused. They might be helpless, and sometimes they might also feel excluded, especially uh, uh, because they feel neglected. So this is when counseling, a proper counseling, is very, very essential, so that this reduces a misunderstanding between the couple. Next slide, please. Now, in second trimester, this is another, as we say, in most of the complications will be less in the second trimester, like BP falls down. So similarly, there are different changes, the physical changes, like because there is increased vasoconstriction of the vagina and vulva, this can improve the sexual arousal and sexual desire. And that sometimes it might be much more higher, especially because first trimester, they were all exhausted and tired. And hypercongestion can also contribute to numerous and intense orgasms. But just like the advantages, these changes can also have disadvantages because there might be vulvar numbness or hypersensitivity. And so these can cause pain during penetration. Next slide. Now, again, last trimester, in most of the women, because mostly there'll be backache, uh, the good fetal movements, then sometimes more amount of vaginal discharge, easy fatigability. So all these problems are there. So most of them, and the sexual desire will be declined by the last few weeks. But for those who are sexually active, they might be, those who have been active, there is not much evidence to advise against coitus unless there are strong contraindications, which we'll see later. Next slide. So these were all the physical changes that we were talking about. Now, apart from there are psychological changes, like mainly because of the body image. There is reduced self-esteem, anxiety, fear of harming baby. Then mostly women might be doing this for the sexual satisfaction of their spouses. Then perceived loss of attractiveness and cultural differences. Again, myths about sexual practice, interpersonal relationships. So all these are going to affect the emotional and psychological well-being of the woman, and this can affect the intimacy and the uh, relationship. Next slide. So these are the various sexual dysfunctions during that is it can affect both the partners. So always a couple should be counseled together. We should be asking them for the questions. Mostly they might be very know um, hesitant to ask or hesitant to open up these problems as what the others might think when we ask such questions. So all these comes into their mind. So they might just keep all these worries in their mind. So in females, again, both males and females are like there is decreased libido, anorgasmia, dyspareunia, erectile dysfunction. So all these premature ejaculation, all these can happen during the pregnancy. Next slide. So these are very often, most of them, nearly 90% have all these doubts in their mind. Is sex during pregnancy safe? When is it not safe? Can it harm the baby? And can the orgasm cause an abortion or uterine contractions? And whether is it increased or decreased during pregnancies? The man's view. So all these questions keep coming into their mind, which they are hesitant to ask. Mostly because again, I told because they might be thinking what the others will think. So we need to be non-judgmental, and we need to be open about whatever questions they have in their mind so that they don't go with the wrong notion or ideas. Next slide. So again, there's nothing like the single best position during pregnancy, and the position in which um, they are comfortable. That is, both the partners are comfortable. This is the best thing. And again, this should be explored and worked out. So over the course of pregnancy, the use of man on top position declines, mainly because to reduce the pressure on the abdomen. So women on top or side to side or rear entry positions are practiced more often. So in any position, whatever we need to advise them is that in any position, the pressure on the abdomen and the deep penetration inside the vagina should be avoided. Next slide. So this is regarding the potential risk, which we, not just the patients or the pregnant ladies and their partners, or we as gynecologists also have apprehension about preterm labor, antepartum hemorrhage. And this is something, venous air embolism, that is something that is in literature. So in preterm labor, there's no clear-cut increased risk in low-risk pregnancies. This is what the studies say. And again, PID, there's no clear evidence to link sexual activity per se. Antepartum hemorrhage, again, theoretical risk with placenta previa, but there are no studies published. And there is something like venous air embolism because it says direct communication between the source of air and vasculature exists in pregnancy. So the pressure gradient is forcing the air into circulation. It can be induced by orogenital sex, fingers and penile thrusting, etc. And they ask avoid air insufflation in the orogenital contact or air entry positions where uterus is at a higher level than the heart. So this 18 deaths in 20 million pregnancies and 19 out of 20 cases of venous air embolism associated with sexual activity was during the pregnancy and pure period. Next slide. Now, again, regarding the complications of coitus, all are the questionable or the doubts that we have. Despite the numerous attempts to link the sexual activity with complications, true risks are largely unconfirmed. So no overall association between sexual activity and either fetal distress or perinatal mortality. And again, there was no causal relationship between the coitus or orgasmic frequency and prematurity, PROM, premature labor or low birth weight. And again, vaginal bleeding and spotting after coitus, most of them, or many women will experience, especially because in the first trimester, but still they have a successful pregnancy. And sexual activity does result in uterine contractions, and so restrictions might be considered in those for whom preterm labor, premature labor is a threat. So that is another finding. Next slide, please. Now, in antepartum hemorrhage and placenta previa, no studies published, but theoretical risk often said. And transvaginal probes have been studied, but cannot extrapolate to the penile contact. And so abstinence would be a benign recommendation because of the consequences that can happen in the placenta previa. Next slide. Again, regarding whether it will induce labor. So, of course, there is theoretical mechanism because we say the oxytocin release from the nipple and gentle stimulation can cause uterine contraction. Again, from the mechanical stimulation of cervix, prostaglandins might be released and can cause cervical ripening. And also in the semen contains prostaglandins, so this can also cause cervical ripening. In population, that is those increased risk, those at increased risk for preterm labor, like with history of preterm labor, twins or incompetent cervix, there is no evidence to suggest a clear benefit from restricted sexual activity. But there is no harm in telling them not to have sexual contact, just as we do cerclage in cases of not just history indicated cerclage. So similarly, we can ask them not to have sexual intercourse. Next slide. So now regarding the advantages of sexual intercourse during pregnancy, again, mostly unproved. So the psychological usefulness, that is the overall satisfaction was correlated with there's reduced stress, the woman is happy, there is emotional intimacy. So all these things, and feeling more attractive in late pregnancy, experience orgasm. So all these adds to the psychological well-being of the woman. Then regarding the induction of labor, the prostaglandin in the semen can favor the maturation process of cervix. So there is better effacement and dilatation. Again, then some evidence that exposure to partner semen can prevent preeclampsia due to absorption of the immune modulating factors, which are present in the seminal. Next slide. Again, all these are unproved. So, next, please click on further. Yeah. So these are the questions. Should we advise to refrain in a normal risk pregnancy? Absolutely not. Unless there are clear contraindications, we need not ask them to abstain. Now, in placenta previa, again, there is no evidence, but again, to prevent or avoid the consequences, the catastrophic consequences, probably we can advise them to abstain. Next. Then regarding the increase, whether it increases the risk of preterm labor, there is no evidence. Again, it might be reasonable to advise abstinence. Next slide, please. So there are certain indications for abstaining from intercourse during pregnancy. There is one is when there is vaginal bleeding. Then, of course, placenta previa. Then if there is a premature dilatation of cervix in the present pregnancy, if there's a rupture of membrane, history of preterm delivery, of course, we can tell them. Then multiple pregnancy, again, depends on the condition. And also any high-risk pregnancy, again, depending on what the condition is. Next slide. Now, after pregnancy, so that is also a very, very important, very delicate period of the woman's life. So very often they again, when they come for a postnatal checkup, again, they might ask, when is it safe to have sex after the birth of the child? So simple, wait until the bleeding stops completely and the wounds have healed and there is normal involution of the genital tract. Also important is they are physically and emotionally ready for sex, but we need to advise them on contraceptives. Next slide. So in most of the times, what we see is generally this is sexual activity is reduced after the pregnancy because of multiple reasons, and in not in India. In other countries like US, Europe, the Middle East, and Africa, the intercourse is resumed generally after 6 to 8 weeks. So by 6th week postpartum, about half the couples will practice intercourse by the 2nd month, and two-thirds by that time, and by 1 year, almost all the couples have resumed intercourse. So, but the coital frequency is reduced. Next slide. Yes, next slide. So what are the factors causing a reduced sexual desire after delivery? A lot of factors, of course, feeling exhausted looking after the baby, lack of sleep, not having proper food at proper time, then having to breastfeed the baby multiple times, and high prolactin hormone levels, then low estrogen level causing dryness, and of course, the postnatal depression, the fear, pain, stress, etc. Sometimes the trauma of the delivery might be there, and also post-cesarean. So all these can culminate in the lack of or reduced sexual desire after delivery. Next slide. So again, dyspareunia. Most of them, nearly half of them have pain during their first intercourse after birth. And 6 months postpartum, 36% of the breastfeeding and 16% of non-breastfeeding mothers still suffer from dyspareunia. That is 6 months, at 6 months. And at 13 months or 1 year, 22% still have problems. So it might be because of the low estrogen level, because of the breastfeeding, and also because of the episiotomy. Sometimes there might be granulation tissue. Sometimes the episiotomy, it might be too tight, or sometimes there'll be nerve issues that is causing severe pain. So all these are said to have a causal relationship. Next slide. So now, again, this is yet another important thing, that is breastfeeding presenting multiple problems. Like infant suckling can be accompanied by erotic feelings in up to half the mothers, and also guilt feelings. And 1/5 of breastfeeding women have problems with contraception or with milk leakage. And then there might be nipple tenderness and fatigue. And also, it has been shown to negatively affect sexual activity in most of studies because of all these reasons. So, women who breastfeed receive intercourse at a much later time and are less interested, and they suffer from coital pain more often. Next slide. So, what we need to be aware is that there are concerns, that is, sexuality concerns during pregnancy, and which they might be hesitant to ask. And most of the pregnant women can engage in sexual activity throughout the pregnancy in the absence of any complications. And all these, the desire, libido, arousal, orgasm, etc., all these will vary during all the 3 trimesters. And even if not for intercourse or the physical relation, couples should keep some level of intimacy going on throughout the period of pregnancy so that the relationship remains healthy. And also, the woman is not just physically fit or physically sound, but also mentally she is sound. Next slide. So these are this is an implication for the research. That is, it's not just the coital activity that should be the best measure of female sexuality. So it should be beyond that. That is the intimacy, the physical, apart from the physical intimacy or the physical relation, the emotional intimacy that should be accounted for, because each pregnancy is unique, each woman is unique. Next slide. Yes. So to summarize, as I said, sexuality in pregnancy is as unique as pregnancy itself, and couples should not be denied of the sexual pleasure and happiness when pregnancy is devoid of any complications, and couple will have plenty of questions regarding this during pregnancy, which we should positively encourage and discuss. Thank you.
Thank you, madam, for that very wonderful, elaborate, and extensively enlightening talk on a very less talked for subject. And we definitely look forward to having more such topics in near future. Such detailed explanations you gave about this pertinent and very prudent topic. I hand it over to the chairperson for the expert inputs. We have Dr.
It's a very, it's a very rarely talked about subject. We looked after so many antenatal patients, hundreds and thousands of antenatal, but very few asked about such questions. Now, after hearing Dr. Sapna's topic, now we are sure what to say about if they ask some questions. That's a very wonderful topic presentation. She extensively touched the topic and covered it very beautifully. Thank you, Sapna, and thank you, AMOG and the KFOG for giving me this opportunity. Thank you very much.
Thank you, ma'am. Thank you, Madan sir and Dr. Prerna.
Yeah. It was a wonderful talk. Sapna, it was a wonderful talk. Thank you so much for
the
yeah.
Very practical tips also you gave.
No, what we find in our practice, day-to-day practices, they might come inside the OP, ask a number of questions about all the medical disorders and about the baby, all these things. And at the last point, the husband and wife will be looking at each other. And then they might get up and go. But then we know, if we don't, if we don't clearly notice, sometimes, okay, they might just leave and go. But, but if we notice that, we might ask them. Usually I ask them, is there something else that you would like to ask? Then definitely they'll open up. So and sometimes they might want the nurse to go outside. So this is what we should be understanding from their not from their language as such, from their body language, that we need to understand. So only then they'll open up, they'll feel close to us, that, and so that they are not left with myth, and they need not go into some porn site or some other magazines or some things like that, or hearsay, all these things.
Very true, madam. You have very well connected the dots between the myths and the facts that revolve around sexuality in pregnancy. Thank you so much.
Thank you. Thank you.
Move on to our next session. Dr. Madan, will you take up?
Yeah, please share the PPT. Yeah.
Okay, fine.
Okay, thank you so much, all the chairpersons. Now we are moving to the panel discussion. We are going to discuss the very important topic, that is the psychosexual issues in adolescent. And for that, we have got the eminent panelist,
Is the slide visible?
Yeah. Dr. Maya Malla from Kasaragod Society, Dr. Sahana from Kasaragod Society, Dr. Rajesh Ravi, who is the Secretary of Calicut Society. Welcome Dr. Jai Krishnan sir, Secretary of Perithalmana Society.
Thank you.
Dr. Thamana Shenoy, Secretary of Malanadu Society. Dr. Zarina Khalid, ma'am, Vice President, Kochi Society. Dr. Elizabeth, ma'am, President of Angamali Society. And Dr. Kaushik, Secretary of Cananore Society. I welcome all the esteemed panelists.
As an expert, we have Dr. Saijis Nair.
Yeah, Saijis will not be here today. He has stuck in some emergency.
Okay.
Yeah, we will continue.
I welcome all my esteemed panelists, and what a string of stalwarts we have all across from Kerala, and my co-moderator, Dr. Madan, for this very, very pertinent panel. And we are talking about adolescence, which is a transitional stage of physical and mental development that occurs between childhood and adulthood, that is 10 to 19 years of age, and influencing factors for adolescent sexuality being gender identity, sexual orientation, the culture the person lives in, and how the body develops. So adolescent sexuality is something like, it's not an individual's thought, but it's a perception as well as response which gets colored sexually. Puberty is an important landmark of sexuality development that occurs in the adolescence, and the myriad of changes that occurs in adolescence puts them under enormous stress, which may have adverse physical as well as psychological consequences. Understanding adolescent sexuality has an important clinical, legal, social, and cultural as well as educational implication in the life of the adolescent. This is interrelationship and domains of development as well as a complex dynamic model which shows how cognitive development, emotional development, sexual development is extended into the progressive and qualitative self-regulated development of the adolescent sexuality. Now, the psychological development in adolescent, we can start from biological changes, which includes puberty, hormonal changes, and secondary sexual characters. And the psychological and social changes affecting sexuality can be cognitive, emotional, social, and behavioral changes. Then the common psychological issues in adolescence are sexual orientation and identity conflicts. Psychological factors are stress, anxiety, guilt, depression, and trauma, premature ejaculation, erectile dysfunction, delayed orgasm, loss of sexual desire or pleasure, myths and misconceptions revolving around sex, and definitely pornography is a new end. We have menstrual problems associated with girls of childhood, marriage problems, early and unprotected sex in teenagers nowadays, sexually transmitted infections, very, very common with the upholding of the premarital sex in teenagers, and teenage pregnancy as well as associated complications. There's so many unsafe abortions we now and then get in touch with, and sexual abuse, which is becoming very common with the advent of so much of social media, addictive behaviors. There is a lot of depression and suicide tendencies in the adolescent these days. So with this, we come to the case one, where we are talking about body image in social media. There is this 16-year-old girl. This is for any of our panelists who can take this up. There's a 16-year-old girl who presents with excessive use of Instagram. She's using Insta for almost 5 to 6 hours a day, and this is very common in adolescents nowadays. And there's a constant comparison with the influencers. There are a lot of social media influencers in the Insta. She feels ugly. She feels she's not up to the mark. Her appearance is not up to the mark. Despite of a normal appearance, she is feeling ugly, and she's avoiding social gatherings and school activities. So I can get this to any of our panelists. Is this normal adolescent behavior, or it's a cause of concern? Anybody can take this. Jai Krishnan sir.
Actually, mild body image concern is common in adolescents. Because they are in the growing up age, they will be very much concerned about how they look in the mirror, how they look in front of their peers in the school, in the society, etc. But if they take it to very high levels, then it is a cause of concern. It is usually a cause of concern when it impairs their daily life. For example, when it affects their study, when they are socially withdrawn, they avoid school, they avoid their friends and peers, etc. And that time, you have to intervene. You have to lend a helping hand for them to get out of this problem.
We can have this from any of our next panelists. How does this body image affect adolescent girls clinically? Have anyone around, Dr.?
Yeah, they may go for extreme freak diets, which may eventually cause a physical problem. So, and trying out all fashion on the internet, try all the new drugs. They may even go and try some medications, go to unlicensed people and try out to improve her body image. So this has to be detected by the parents or school teachers and acted accordingly upon.
Very well taken, madam. Yeah, as care provider, our motive to put up this question about body image was that we have to encourage these girls who come with such a problem that no body image is something what we can call disfigurement, because every body is beautiful and they need to actually admire themselves, and what they have seen in the social media is not that what actually in the personal life. So this particular thing has to be communicated to these girls, because we have a lot of body dysmorphic disorders that is coming today's in psychological issues related to adolescents. So anybody or any other panelists have anything to say on this BDD, body dysmorphic disorders? We have Dr. Ronak, Dr. Do we have Dr. Elizabeth and Dr. We have anybody else from the panel? Sahana? Yes.
Yeah, madam, actually,
please. Yes.
Body dysmorphic disorder is when you deviate from the normal. It's quite natural when a girl starts to grow, when the secondary sexual characters start developing, and when you start looking at your friends and peers and start comparing yourself. But when it becomes in excess, as Dr. Jayakrishnan already said, when it goes beyond a particular control, when they go ahead doing things which are not in the normal norms, then it becomes a disorder, and we need to then go in for a help. They might even need medications for that later on. So that depends on how quickly the parents can pick up that they are turning into something which is away from the normal. And I think for such a thing, the change in sexual changes should be brought in by the parents to their wards a little earlier than these changes start beginning. And I think, especially in India, parents consider it have a great difficulty in talking to their children regarding sexuality and the changes the children's body is going to come about with. And I think the schools are now implementing a lot of sex education right from early age, but I think it should start a class or two earlier before the onset of puberty.
Yes, madam, very well taken. So the counseling is the key, and good counseling can come from people from school, from the parents, and the parents should also handle these situations in a very sensitive manner. But there's something called the social media, which is worsening the situation in every case. So this is where we need to be vigilant as parents that social media should not worsen once already the child is into such a trouble. We have to make this child come out of it and then understand what her sexuality actually means and what is her body image is all about, and nothing to be doing with the social media influencers around. But she should have some people around her to share with and to tell what she feels about it. So
Can have the next slide. It's not moving. Yeah. So mild body image concern is common in adolescents, but functional impairment, social withdrawal, they need early evaluation to prevent mental health illness. They can lead to eating disorders, menstrual irregularities, which is important. And there can be a misperception about their healthy bodies. So there are preoccupation and minor existent, non-existent flaws, repetitive behaviors, significant distress with social withdrawal, and requires cognitive behavioral therapy. And this addresses negative thought patterns with building of self-esteem and coping, encouraging real-life social engagement. Awareness programs are definitely the clue, and avoiding criticism or comparison between your own children and with children of your colleagues. That also gives a lot of discouragement for these children. We need to encourage open communication and monitor their screen time gently. We cannot just force them that don't watch TV, don't watch Instagram. We have to do it in a very gentle and very sensitive manner, because that is how we can reinforce a child's strengths and then his or her abilities to cope up with the situation. So unrealistic beauty filters and editing algorithm promotes comparison validation culture, and we need to recommend there has to be screen time limits and digital literacy education in our children. So that's a very important message that we want to give from this particular question. Over to you, Dr. Madan.
This is another interesting case. A 15-year-old schoolgirl who is in a relationship with her classmate, and she used to she's actually her use of phone is increasing day by day and with secrecy. So that is affecting her academic performance, and at the same time she has anxiety and fear also that parents will find this her relationship and she will get punished, and she is under stress. Then how to go about this case? Yeah, next slide. Next slide.
Somehow it's not moving. I don't know why.
Can I share if you want?
Yeah, it's moving.
Yeah. Okay.
Yeah, I think it's a change.
Yeah, there are so many questions regarding this. Is early romantic involvement normal at this age? And what are the potential risks in such cases? Yeah, anyone can take this question.
Hello,
Is
sir.
it normal at the age of 15? Yes, Dr. Shana.
Yes, sir. Actually, at this adolescent age, it is like this attraction and curiosity is normal only. But when we have to we have to give attention is if it is crossing the limit. Actually, we have to monitor the students, adolescent age group students, and if there is a decline in their academic performances, they are taking over stress. Then we have to give them guidance and proper counseling, everything. But actually, that is normal in that age group. But crossing the limit is the problem, sir.
Yes, counseling is very important. At the same time, we cannot punish them. We have to handle just like a glass, handle with care. Then what are the potential health risks? What can happen if they indulge in the sexual activities?
Yeah, actually, at this age, if this attraction is common, but the problem coming to early sexual activity, unprotected intercourse, sexually transmitted diseases, teenage pregnancy, and that all are the problems coming in this age group, sir. For this, actually, proper sexual counseling is needed. That age-related proper counseling is needed for this, sir.
Then out of that, again, the child may go through the psychological issues, may have anxiety, depression, basically, and many times suicidal tendencies also in this such cases. If the parents try to punish them, or definitely there is also a role of school. What is the role of school according to you? What school can do in such cases?
In schools, actually, is having playing a big role in this, sir. Actually, they can conduct counseling sessions. They can give a class about what are the healthy relationship, what is this. Open communication can be given. Do not invade the privacy abruptly. Guide rather than the control. And they have to discuss among the students what is the problem. And actually, all the discussion, all the counseling should be confidential.
And yes, that is very important. To maintain the privacy is very important. Of course, there is
And
a role of
in
parents.
schools, they have to identify their academic performance also. If they have declined academic performance, they have to rule out all other courses also. Not only the student is, everyone, the student is lazy and they are leaving. Behind that, what are their activities at home? What are their mindset? Everything actually starting from school, and the teachers is having an important role in all this.
So I think we should involve the parents also, because it has legal concerns also, as far as the age, because they are under 18. If they indulge into the sexual activities, or by chance that the student becomes pregnant, then everything spoils. So we have to be along with the parents also, and inform the legal issues like POXO Act and other acts also. They should be aware of this fact. So next next case.
Moving a bit slow.
Yeah, I think Mayur can share from his end.
If you allow me, I can share, ma'am.
Yes, it is in the group. Please share from your end.
Yeah, stop sharing, ma'am. Then I'll share.
Keep
Is it
moving.
right, sir?
Yeah, keep moving. Yeah, keep
Go
moving.
ahead.
Move.
Yes, we will start from here. Okay, there are some interesting cases. Yes, back, one slide back.
One slide back, Mayur. Kindly move to the previous slide. Mayur, kindly move to the previous slide, please. I think Dr. Madan, the question we have, yeah. No, the
back,
previous one.
Previous. Back, Joe, back.
Previous slide.
Yeah.
You're not moving it to the previous slide. Please move it to the previous slide. Yes.
Prerna, will you take? I have an emergency.
Okay. This is a very interesting scenario regarding a son. You have a son who and the son when you found the son. So how do you react? What next? Can you hear me?
Madam, your voice is breaking. Can't hear properly.
Dr. Madan, can you hear me?
Ma'am, your voice is breaking. Actually, unable to understand what you're speaking.
Mayur, next slide. Mayur, next slide.
Is
it right,
very unstable. Please take it up. My internet is unstable.
Mayur, next slide.
Dr. Madan, please take this up. My internet is unstable.
Mayur, next slide. Next case. Be fast, please. Next.
Adolescent sexuality, sir.
Yes. There is a interesting case. Suppose you entered the room of your 16-year-old son and found him masturbating. Then what next? What is your take on this? What you will do? Yes, anyone can take this.
Actually, what most of the parents will do is get angry with the his ward and just scold him, and all this will make him more what you call anxious. Actually, what actually should be done is will tell him, make him comfortable, and build rapport with him, and tell him that make the situation more comfortable, less awkward for them. Explain that masturbation or wet dreams at nights are actually natural phenomena. There is nothing to feel awkward about this. They are just natural physical phenomena. And all, but also explain to them that they should watch about privacy, and just to maintain what do you call hygiene, body hygiene. All those things only need to be explained. Just explain to them also that because many of them at school, their fellow students will be telling that if you masturbate, then it will lead to serious health problems like sexually transmitted diseases, or even sexual what do you call sexual what do you call impotence in later life. You should tell them that such things are not real. It does not affect your sexual performance or your reproductive performance in any way in future. It is just part of your normal aging, growing up age.
Yes, sir, you are absolutely right. This should be the counseling actually. And we have to give him the right education and right counseling at this age.
Yes.
Yeah. What he is doing is absolutely normal. Next slide. Yeah. Yeah, next slide. Okay. We have to build a rapport. Next, about this sex education. Should sex education be a part of school education? And what is the appropriate age? And who is the right person to teach the object?
Sexual education, yes, sir. Sexual education should start around the age of 6 to 8 years, and it's a must because once they grow in adolescent group, and afterwards, if they land up in some problems, it may land to some psychological problem or behavioral problem. It's better to start early in the age, and it's the duty of both parents, teachers, and also socially like doctors like us. We have to take part in this, and most importantly, we have to teach about the anatomy, about menstruation, and the psychological changes, body changes, and cognitive this one unprotected sex and sexually transmitted disease, and how to respect the opposite sex also. That is also important for both the sex. We have to teach how to respect the other sex people, whether it's a male or female or any other sex. And we have to tell the importance of consent, and how these social medias are influencing on the adolescent group, and how it may change their future also. Sometimes their mental health and physical health, all those things we have to teach them. It's the responsibility of both parents and teachers.
Thank you, madam. Rightly taken. Next slide, please. So adolescent sexuality and sex education should start before the puberty, and at least 6 to 8 years. Most important issues should be anatomy, menstruation, hygiene, and consent and privacy, as well as contraception. Responsibility of the parents, right amount of information, and at the right time is necessary. I have to switch off my video because the internet is a little unstable. I hope you are able to hear me, sir. Sir, Jay
Yes,
Krishnan,
sir. You
sir.
are quietly audible. You're perfectly
Okay,
audible.
fine. So I'll keep my video off. I'll keep my video off. So next slide, please. Next slide, please. So sex education should be a part of school curriculum in India, and nobody gets left behind. Young people are always inclined to have sex. By putting sex education on a curriculum, no child gets left behind and is left vulnerable without the knowledge to make informed decisions and protect themselves. Because sex education promotes healthy living. We teach the importance of exercise, healthy diet, and good oral hygiene in schools, but we do not teach about good practice of sexual health. As the Young Talent Promotion Committee National Coordinator, we have taken this initiative of responsive awareness in young adults through sex education. That is a promotional thing by the Foxy YTPC that we are doing in various schools, and we are astonished at the number of questions and the pattern of questions that these students ask. A student of class 6, they ask how good is to have intercourse with the different partners in different sessions. These are the level of questions that they ask. So where are we? We are teaching about good touch, bad touch, and these students have gone way beyond good touch and bad touch. So sex education it has to be a more inclusive environment, and a comprehensive sex education program includes LGBTQ relationships as well, which can help make schools inclusive. And sex education reduces pregnancies and STDs in our country, and in countries where comprehensive sex education, not just abstinence programs are there on the curriculum, unwanted pregnancies and STIs definitely will decline. Next slide, please. Next slide. So these are the cons of sex education, that every child is different. We cannot rate teenagers and children at we cannot apply one size to that will fit to all. Like for a child of class 6, something which may be very haywire, for a class of even child of a child of class 10, that might be something very naive and new. So we have to understand what the mentality and what the social strata of that child is. So we need to teach the instinct of humans that manage perfectly well for millennium without formal sexual instruction, and we need to teach something that is innate. Now, sex education is a waste of valuable class time, some people can think. So, but this is something which a classroom has better spent on subjects that parents can't teach effectively. There are a lot of parents who can't even tell their students or tell their wards about sexual intercourse, that this happens between a male and the female, and the female genitalia and the male genitalia are involved. They don't even tell this to their children. So this is the reason where we care providers have to creep in. So this allows teachers to promote an agenda, and many educators have their own personal views on matters like contraception, abortion, and LGBTQ matters. So we need to have a thorough discussion on all these. And sex education in school should allow the agenda to push into between children and teens, that how well sex education has to be taken care of. Second, next slide, please. Next slide, please. So when interacting with the students, is there anything that Madam, Maya Madam, or Jai Sir, or Jarina Madam, you have come across while interacting with students when you're going to some school, that about the knowledge of sexuality among adolescent girls and boys? Like my experience was very, very horrible. My experience was very, very horrifying, in fact, because every time we are going for last 2 years to different schools, and every time we give anonymous chits to these children, and the questions that come back to us are really very disturbing at times. One girl, she said that she said she was in class 6 or 7. She said that I kissed my boyfriend the other day. I kissed a girl. Everything sounded very different. So whom should I kiss more? Like these are the questions. Like they are not even very sure about their gender identity. So it's really very relevant to speak to these students about this. What is your opinion, sir and madam?
I think the social media and free exposure to all this has made children very precautious, and it's difficult for us to digest this question. But in their strata, I think they think it is normal. So it is very important that sex education is given much at 6 to 8 years of age, and the exposure to media cannot be avoided. And of course, it is under parents' control. But how far the control is nowadays is very difficult to say. It's so easy to go onto a mobile. So, yeah, it is a very, very surprising experience talking to these kids and answering the question. Like just like your experience, I also was shocked with the few questions asked by these girls. I think the control should be on the parents.
Yeah, I have come across one mother who got her daughter, who is around 15 years in SLC, as your first case. Mother is telling she doesn't have any interest in studies, and she's already having intercourse with a boy who is I think this food delivery and all, that person. She's already having intercourse, and that girl was wearing a makeup like celebrities, and she's telling it's okay for her. And I explained everything, like what all can happen with unprotected intercourse, and I was explaining about her what is the importance of education, and anything can go wrong between the relation, and afterwards how it may cause a mental problem and all. And more than the girl, no, girl is very like She was not bothered only about anything. She was explaining everything very interestingly. Mother was very worried. Girl was not at all worried about her sexual relationship, and she was not worried about getting bad marks in the school. So, as you told, nowadays it's very difficult because of all social media and their way of thinking in life. And I think nowadays kids have not seen what to tell, bad days. So every mother or parents will give them this one independence for everything, and they'll get whatever they need from the childhood, and they don't know exactly how to go ahead. So I was counseling her, and afterwards she did not turn up. More than her, her mother was worried. She was not at all worried about all these things.
Yes, madam.
She
For
was
them, nothing
joyfully
is
explaining.
abnormal.
Yeah, she was joyfully explaining everything. And she was telling it's okay even if she doesn't study.
Yes.
She's happy
Jai
with
sir?
it.
Yeah,
Yes.
the scenario is actually very disturbing.
Yes.
Very
For us,
disturbing.
for people of our generation, this is very difficult to get used to, get
So for every
understood.
generation it is.
But somehow you have to get used to this reality and change our counseling method, change our attitude towards these teenagers.
Yes,
And,
yes.
Next slide, please. Next slide. So this one is a very interesting scenario where 19-year-old unmarried girls come to your consultation and stay in a steady relationship with a boyfriend and wants to take things to the next level. Now we want a contraceptive advice for this 19-year-old girl. How will you guide her? Prior to taking up this question, I would like to share one of my experience where one of my patients, she is going to study in Australia. She was 16 years old and she was brought to me with her father. The father had come and he said that, doctor, please prescribe her OC pills for 6 months because she's going to stay with her boyfriend in Australia. Now I was really shocked. This happened just a couple of months back, and then this particular panel we had made. So very disturbing, or maybe not disturbing, so very open, and
as
maybe
if she is
that.
going to Australia only for this.
Yes, maybe I don't know what was, and she was going to study MBA, but then too much to handle. I said, no, we cannot prescribe it for a 6 months duration at a go. So, Madam, Dr. Maya, Dr. Tamanna, please take this up.
No,
how will you guide her?
I think there's a debate even in us gynecologists whether young girls should be prescribed with contraceptives or not. But actually, ma'am, looking into the fact that there are so many FIRs being raised against boys because of these unwanted pregnancies that occur in the young, I think a short duration of contraceptive pills for the girls would be ideal to prevent such unwanted pregnancy, along with it, a barrier contraceptive to prevent sexually transmitted diseases. Because the world is growing, we are in an AI generation now. And these implications like multiple sexual partners and live-in relations cannot be avoided. So we have to give them something to protect them from a premature pregnancy as well as from the sexually transmitted diseases.
Yes, madam, very well taken. Can we have the next slide, please? Prevention of STIs is the most important. So best practices is a holistic approach. We by this time we all know the nature of the sexual relationship has to be very much ascertained because they might not always do the vaginal intercourse. That's a very, very high risk of having absurd ways of having penetration. There has to be a proper sexual history, whether she is going on with multiple partners, whether what's the frequency of her intercourse, risk of STIs, have already rightly verified on this, and medical eligibility, whether she is eligible for having an OCP advice, whether the efficacy of the method is okay, whether the ability to tolerate the side effects is fine, whether services are available and cost effective for her, whether her religious beliefs are allowing them, and the partner's attitudes, as well as the lifestyle issues has to be taken care of. Personal factors also compliance to there are times when she might be staying in an area where these OCPIL for even the young girls is not very relevant. So next slide, please. Next slide, please. So the different options of contraception available, I think everybody will go for more with barriers and occipitals, I suppose. Jai sir, Jarina madam?
Yeah.
Yeah.
Occipitals and barriers. And
And,
both together would be ideal. But
okay.
I don't know whether how successful we will be with making the girls eat occipitals. There
Yes,
should be
madam.
from the parent
That is-
side, from the mother side.
I think
They
if
should
both the
Next.
partners are okay with it, barriers
Yes.
methods like condoms will be more preferable, because at the same time it will prevent pregnancy, and at the same time it will prevent STIs also.
Apart from the panel questions are a very practical question that we are problem that we are facing in our day-to-day clinical practice. In this part of the northeastern India, every now and then, every day, almost 1 or 2 girls are coming with a popping of eye pills and popping off of abortifacient pills. So very common. So they think that eye pills and abortifacient pills are a way of contraception. This particular percolation of the information into the masses is very, very important, that OC pill is a safer option, and eye pill and abortifacient pills are way unsafe than having a continuous OC pill. So this is a very important and point of information which we can give to adolescents whenever they come to our clinic for any sort of issues. We can ask them just a question whether you are a virgin or whether sexually active. If she's coming for menorrhagia, if she's coming for PCOS, if she is coming for any sort of pelvic pain or white discharge or PID, you can just give her this piece of information that if you are sexually active anyhow, then please go with OC pill rather than going for eye pills or abortifacients. So this particular thing I felt like sharing with you all. So next slide.
Right.
Not only in Northeast, madam, everywhere the same scenario.
Yes, everywhere, very much, madam. Next slide, please. So the options we have all discussed. Next slide, please. Next slide. So parents and doctors, in the last webinar, we had mentioned about this. The parents have to behave like best friends. But my personal take is that parent has to be a parent. Okay, you can behave like a friend, but you cannot be a friend of your child. Okay, what I feel, Jai Krishnan sir, Zarina madam, Tamanna madam, what do you all say? A parent has to be a parent. Okay, parent can't be a best friend of your child. If that is so, then it will become like they take us for granted. I feel so. I don't know. So what do you say? Definitely, a communication has to be there, but we have to be strict at times also.
I agree.
Yes,
Yeah.
we have to be. Yes.
You have to be open with each other. That is the main thing.
Yes.
You have to be open and don't keep
is
secrets. Don't keep secrets. That's it.
Madam, I'll share one. Yes, please, Tamanna, madam.
You can be an understanding parent,
Yes.
but not a friend. You can be someone where the child can rely on, and give the child the space also. Give him his space, give him some kind of self-integrity by giving him his own time and space, but definitely be a parent and not a friend.
Yes. On this, I'll just share one experience of ours. There was this party we were sitting, and a couple of doctors from other city were also there. A city which was little more metropolitan than what we live in. And then we were just discussing about our children's affair with some other with their group of peer people. So then one of the doctors, he said that nowadays I tell my boy to bring the girl home only, not to go to any hotel. So why? Well, what was that? She said that it's safe at home. Every weekend, if you get one new girl, it's better to bring the girl home rather than take the girl hotel. So I have opened up my house like that. So how rubbish was that? So how can you do that? You have to sit and explain your boy that taking a girl every weekend, a new girl, that is not the right thing to do. Rather than that, you are just opening up your house for so that amount of friendship also can be very, very hazardous to the child. So next slide, please. Next slide, please. Next slide, please. Mayur, next slide. Yeah. So we will come to a conclusion of this particular panel, which has been very interesting with all our esteemed panelists. I would like to take one take-home message from Maya Madam, Jaya Sir, Zarina Madam, Tamanna. One take-home message from each one of you. Jaya Sir.
You have to be friendly, and at the same time, you have to take a stern action in some cases, and you have to speak openly with your children and educate them.
Thank you, sir. Maya Madam.
I feel sexual education is must from younger age only. And I think somewhere we have to tell the children that till they finish their basic education, brahmacharya is better. That's what I tell. Because once they get turned towards the opposite sex, and if they cross the limit, most of the time they lag behind in their studies.
Yes.
Yeah,
Yes.
studies they
Correct.
lag. I tell once they finish the basic education, like you told, somebody wanted to go to do MBA, going to Australia. She wants some contribution.
Yes.
It's okay. She has finished her basic education and she knows what she is doing. She is mature enough to handle it. As how we tell that the child marriage is not good because they are not mature enough. We have to tell the children that they are not mature enough to handle whatever consequences they are going to have once they have the sexual intercourse with the person. The person may misuse them, and the person may afterwards do any blackmail for them, and the person may cheat them, and they may go in for wrong relationship, and afterwards they may go for depression, stress, everything.
Very true.
So
Very
till
true.
they finish their basic education, they should know their limits.
Very true, ma'am.
It's okay that they should get attracted to other sex, but it's okay. But they should know the limits till they finish their basic education.
Very true, ma'am. Zarina, madam.
Yeah. As gynecologist, I mean, we have been asked not to be judgmental. Yeah, don't be judgmental. But at the same time, make sure that the proper sex education is given, and make sure you go and give classes to as many schools as possible and spread information about the safe practices. And we can't prevent them from engaging in this after looking at so freely into the social media, but give them proper advice so that they will not have land up in any issues. So I think prevention is the only way.
Very true, madam. Tamana, madam.
I think definitely OCPs and barrier contraceptives to all sexually active adolescents and their parents. And as Madam mentioned about iPill, I think there should be a norm where this over-the-counter pills should be, restricted, just like MTP. Nowadays, you don't get these MTP pills available at the chemist over the counter. Even iPill should, be restricted drug. Because there are a lot of ectopics also happening because of this misuse of unwanted iPill and unwanted pills.
We as
Sahana, madam.
gynecologists now we should strongly discourage the use of IPIL in out of place uses.
Shahana, madam, if you're here.
Actually, my opinion is like this sex education is not only for adolescent girls and boys. It's actually we have to give one for teachers and to parents also, because I feel many wrong information are going from teachers and parents to kids, and the over restrictions also leads to the kids are going for wrong because of the over restriction also. So proper education not only for kids, to everyone, to parents, to teachers, and how to counsel and how to monitor, that information should be passed to everyone in the society.
Very true, very true. So if we do not have any more panelists with us, we can conclude this very, very prudent panel, which is the talk of the day in every house, every social circle, and every community. So this is a very, very burning topic, the effect of social media, the effect of peer pressure and everything. So these adolescent minds are the most versatile and the most vulnerable minds, and they are not matured enough to take informed decisions. So the responsibility of the health provider, the teachers, the caretakers, the parents is immense and multiple fold to take them to the right track. And thank you all the esteemed panelists for a wonderful session. We really enjoyed it a lot. And every good thing has to come to a conclusion. And I extend my heartfelt gratitude to all our chief guests, our guest of honor, and our chairpersons, our speakers, our esteemed panelists, and all my co-moderator, as well as our tech support. So have a pleasant evening, and signing off till we meet next. Thank you, Kerala. Thank you all.
Thank you, madam. You managed it very well. Your time management was very good, madam. Thank you.
Thank you, sir. Thank you. The network was putting on some issues, sir, but then we tried level best to
You
make
did
it
very
good.
well, madam. Thank you.
Thank you.
All
Thank you
the
so
best
much
for your tenure.
Thank you.
This
We'll
1 year.
keep you we'll keep you glued on. We'll involve you all in all the work of the activities, because we have been suggested by Ameya sir and also Ashwath Kumar sir that this is the most vibrant lot of Kerala people that we had included in our webinar today. Thank you so much.
Thank you, madam. Thank you. Thank you all.
Good night.
Bye-bye. Bye-bye.
Bye. Bye-bye.